Pete, we recorded the last podcast about 6 weeks ago.
Yep.
Much happened since then.
I do love the fame trial. There it is. I said it. I
said it.
I love it.
Just be proud, Pete.
Let me tell you why I love the fame trial.
There's always been this kind of slight mystery of pharmacies. You know, nothing bores me more than one.
He's going to give you 5 take-home messages from the COVID experience. Things that we've learnt from the COVID experience. What would those be?
You've got 5.
I haven't got 5. So 5 things. What we
Run up your list. Have you got a list?
No.
No, yeah. I mean, if you're on a ventilator, it's pretty bad news, isn't it?
It's pretty bad news. Yeah.
That's about as much as we're going to offer on COVID, I think. Masturbates. Listen, I need to stay 2 meters away from me, okay?
Okay.
Social distancing episode. To be honest, that was my rule with you even before COVID. 2 meters away from base. It's so bizarre being in the... So we're both here for clinical reasons, here on a Sunday.
Yep.
And it's so bizarre being here. I mean, we're in the Blizzard Institute at QMUL during the lockdown on a Sunday.
It is dead. Normally there's busybodies running around everywhere, people with lab coats, people holding beakers of stuff with smoke coming out of them.
Yeah, I think you're thinking of the Muppets. Was it Benson and Beaker? But it's so bizarre because I normally get the tube in and I've just driven here.
Yeah.
Honestly, I was probably doing about 25 miles an hour, but I felt like I hit 88 miles an hour on the Whitechapel Highway. It was like Marty McFly getting away from the Libyans.
But and there's some great stuff on Twitter about maximum speeds being clocked on various roads in London.
Yeah. Just to be clear, I didn't break the law in any way. So, Pete, we recorded the last podcast about 6 weeks ago.
Yep.
Much happened since then.
No, it's been pretty same old.
Yeah.
There really haven't been any great changes in work. I thought one thing might be interesting, because nobody else has done it. It'd be interesting just to have a chat about this COVID thing, because nobody else has really covered it, have they?
Haven't they?
No.
It
hasn't really been discussed anywhere. I
doubt
there's a bit of a paucity of literature, I would say.
Yeah, I imagine there's not many podcasts about it or webinars.
No.
And certainly no articles.
No.
So perhaps we should have a bash at it.
There's some quality literature though coming out of China, isn't there? Some great stuff coming out of Wuhan province.
There's some interesting literature. I was being slightly facetious in the webinar when I said if ever you wanted to publish papers with low case studies, no control groups, now's the time just to bang them out.
Yeah.
And I predict there's going to be a tsunami of COVID-related orthopaedic publications.
If ever there was a word used not to describe a tsunami, but to describe things other than a tsunami, it's the word tsunami, isn't it? It's been used a lot.
I was going to first say it's unprecedented.
Yeah. Because there's the tsunami of COVID patients, and then there's the tsunami of articles about them, and then we've got to have the tsunami of cases afterwards of like knee arthritis, ankle pain, rotator cuffs, wrist pain, and all of that. So it's going to be, we get to use the word 3 times.
It's been a strange time. Since there's this lack of elective operating. There's still lots of horrendous trauma about. There's a lack of human contact. People crossing the street every time you see someone coming. You know, not doing any elective operating whatsoever. It's kind of made me realise that this is what life must be like for you all the time.
It's trauma. Great. It's just trauma. Just
miserable.
This is my life. Yeah.
Since we last met formally for this, COVID, we kind of knew it was something in China.
Yeah.
And then there was a whiff of it in Italy, but we thought, well, okay, that's just the Italians, right?
Managing it poorly. Yeah, you would expect, if it went to Italy, you'd expect them to make a mess of it, wouldn't you? That won't happen to us. We are all over this. We are all over this.
I mean, I'm sure we've been planning for 6 months. I'm sure we've got stockpiles.
There's no way we're going to fuck this up.
We must have stockpiles of PPE and full, plans and mitigation.
Hazmat suits, a go-go.
All that. And yet, here we are. Here and now, in the first week of the extended lockdown.
That's it. The Sunday papers are absolutely going crazy this morning, aren't they?
It's been interesting because there was a time where we had pretty much 1,000. There was a point where we almost had 1,000 deaths a day. Yeah. And the front page of every newspaper was kind of Boris Johnson is sitting up playing Mario Kart.
Yeah.
And you're kind of like, it doesn't quite. There's a bit of cognitive dissonance there.
Yeah. I was speaking to one of my ITU colleagues this morning, and he was telling me about how it's feeling up there. They're on pretty tough rotas, those guys, and it is pretty draining. So I was asking about what happens to people. So if you end up on a ventilator, what's your likelihood of surviving if you end up having to go past just positive pressure onto a ventilator? He said it's about 50-50 in their experience, at least. They're half of them make it, half of them don't.
No, yeah. I mean, if you're on a ventilator, it's pretty bad news, isn't it?
It's pretty bad news. Yeah.
That's about as much as we're going to offer on COVID, I think.
Okay, let's wrapping that one up.
So let's do the next one. We changed our way of working completely. I think a lot of people did the same thing. I mean, we saw it coming, and we changed all our rotas and cancelled all elective operating early, ahead of official sanctions, as it were, from government or from trust.
Yeah.
And we've kind of we've rejigged the way we do everything. And
I think about pretty much everyone in the country has. Everyone took a position on their elective stuff, and they ramped it down pretty quickly. And I think every orthopaedic unit in the country almost has kind of boiled themselves down into like an emergency rota situation where you've got a core of people representing every subspecialty each week, and they work in a more of a shift-like pattern. So any operation can happen any day, and that's pretty much what we've done as well.
In a variety of places, and most people have lost junior trainees. And it's resulted very much in a consultant-led service where decision-making is made on first contact. And often first contact with the patient may be their definitive treatment.
It is shocking, isn't it, how little the rest of the hospital want orthopaedic surgeons helping out, though.
Yeah, they want to keep us miles away, don't they?
It's not like we haven't offered our services. Need any help from the orthopaedic consultants around your intensive care units? Or the medical wards? Any help required? Stony silence.
I think your reputation precedes you. So we've sent this... I was going through my emails, and I sent an email out on the 31st of March, 19 days ago, to you and Mike, just saying, well, look, we've been doing these, Pete and I have been doing these master tutorials online for years, messing about. And that's kind of what led to this podcast, because this is essentially a version of the tutorial distilled. And then all of a sudden, we decided to stop our regional SPR teaching quite early, because we couldn't afford to have that many people away from work, that many people in the same place. And we figured, let's do some online teaching for our local trainees. And then we were spitballing, and it kind of grew into, well, why don't we make it available for everyone online who's interested?
What's spitballing?
Shooting the breeze.
Okay, all right.
Chatting shit.
Okay.
However you like to do, conversing. But I didn't expect it to get to the stage where all of a sudden we ended up with authorhub.xyz.
Authorhub.xyz. XYZ was your thing, wasn't it?
XYZ. I wanted the XYZ, yeah.
Why do we have to put the Z in there?
It's a known kind of suffix for them, and you can't have .xy.
Okay.
And we didn't have authorhub.com was taken. I don't know who by.
Yeah.
So I quite like XYZ, and it kind of fits. But I didn't expect over 200 people to sign up and attend the first webinar.
Yeah, that was awesome.
What did you think about the webinar?
Well, it's very topical. I mean, we're one of the, as we said earlier, we're one of the very few groups who've actually decided to talk about this COVID situation.
Yeah,
it was nice to webinar on that, because I think that really broke.
No one's mentioned it. No one has mentioned it.
The webinar went well. We centered it around non-operative treatment, which is kind of where we're going to drift this conversation shortly. We talked about non-operative treatment because actually, what this COVID thing has done, because we're so constrained on the anaesthetic side, and so a number of theatre access has been shrunk right down, it has made us think about what we operate on. There really is no place for operating on stuff that doesn't absolutely need it now. So we have to think about our indications pretty hard now in a way that we never used to. Because basically we are in a culture now, aren't we? An orthopaedic culture of fixing pretty much everything.
I was in a Twitter conversation this morning, and one of the things that came up was that I was asked that do we think that there's going to be a drift back towards non-operative treatment once this is all over? And I got a feeling that I think more people will be open to it than they were before.
I think more people will be open to it for sure. One of the interesting things that came out of that webinar that we had was you have your webinar, and then you got all the Q&A down the side, and one of the questions that popped up literally recurrently throughout the webinar was, are we going to get sued? Are we going to get sued? In fact, Alex Trumpeter answered the question once, and then someone started asking it again, and we had to ask him again because people do not feel comfortable around it. They really don't. Treating distal radius non-operatively, it's like, ooh, it's a real taboo still.
I think everyone is in a situation where life has changed in every possible facet for everyone. The minute you're outside of your comfort zone and your normal way of practice, it's quite normal to feel stressed or unease. Yeah,
for sure.
So I can see why people are looking at that way, but I do think that there's going to be an increase. So Xavier Griffin tweeted me and he asked me, do you think there'd be an increase in equipoise towards things such as the FAME trial?
And isn't it funny how FAME trial, it's just very ironic how FAME trial, which really is challenging a lot of people, has been interrupted by this COVID experience. One of the I'll just come back to that in a sec.
Sure.
One of the things I've noticed is that because, so our theatres are constrained, so we've got lesser ability to do operations, but at the same time, we're a lot quieter. The number of minor injuries have shrunk right down. Most hospitals have some other outlet where they can do, like these minor injuries. Like, for example, we're using the private sector in London. I know, for example, in Nottingham, they've taken over the local independent treatment centre, and they've done that at Queen's as well. And they've done it. So every hospital has found a way to outsource some of its fractures to non-COVID units. And so the result has been, actually, there has not been this mass change in practice. That's the weird thing. You would expect us all to be going non-op, non-op, non-op. But of all the units that I've spoken to, actually practice has not massively changed. And people are still fixing distal radius fractures, and they are still fixing ankle fractures.
It really comes down to access to theatres, and that's the key rate limiting step.
And if you give orthopaedic surgeons access to orthopaedic theatres, by God, they will use them. And that's really what we've seen. So I haven't really known. I mean, it may change as injuries start ramping up, as the lockdown eases over the next few weeks, but yet we're still very constrained. And it'll be interesting to see how this turns out. But at the moment, that huge transition of orthopaedic care to non-op hasn't really happened in the units certainly not in our unit, and I haven't seen that elsewhere either.
We certainly had to change some of the things that we do. For instance, there was a multi-ligament knee injury that normally I would have operated on acutely, but there's no physio available whatsoever for rehabilitation.
That's absolutely
right.
So
you can have, so if you don't operate, you risk stiffness and a poor outcome, or you can operate and risk stiffness and a poor outcome if they don't have that rehab. So that case, we've put it off for now, and it's been temporised.
Yep.
But the fact is that I think some of the issues we're kicking down the road, as it were. Not directly, and we're not looking to neglect these patients, but there is going to be a wave of issues of people who perhaps didn't get the definitive treatment at the time, who are now going to represent in
there will.
a few months' time.
So, and I think that's one of the things that really has drawn our focus after this crisis, is that we take a lot of things for granted in orthopaedics, and one of those is physio, and we're actually pretty poor about communicating our desires and how we think rehab should be done. Maybe not all of us are, but I think us as a community, we probably hand over to the physios and let them crack on with it.
I think a lot of the time our involvement goes as far as giving a weight-bearing status and kind of saying physio as a generic black box.
And one of the useful things that's circulating around on the various WhatsApp channels that we're all party to now are sheets of physio advice of how do you rehab your wrist, how do you rehab your ankle after a particular injury.
I've not seen any of those.
Have you not?
I'm still getting pictures of Barry. Honestly.
That guy's dominated the airwaves, hasn't he?
Dominated. I've not seen anything about physio, but you'll have to send it to me. And I've got some stuff I'll send your way. The thing that's interesting, looking at people's practice and hearing about practice around the country, I think there's a real delineation between trauma still in London and outside. We've still got big construction sites still working, huge construction sites are still going on. The fact is we're still getting high energy trauma, and there's concern that people had was that people may be more socially and mentally vulnerable and looking to kill themselves.
That's something we've really noticed is the spike in self-harming patients. Yeah, and it's a fall from height.
And the jumpers, they don't stop. They never go away.
They never go away, but there does seem to be more of them lately. Now that lockdown's been going on for a while, and these people, it's almost like they're like, I can't bear this any longer. I have to get out of here. And the thing about the jumpers is they never quite go from high enough. They never quite jump from an adequate height. They say 7 to heaven, but even now that's not, 7th floor. Even now that's not necessarily true.
I think we're going to have to revisit that.
Yeah, that's right. And it's a real testament to the pre-hospital guys, to be honest. Certainly around this place, that those guys are, it's actually very difficult to kill yourself nowadays by jumping off a building. It's not a particularly effective mechanism.
It is not effective at all.
Because the guys who pick you up will get you into hospital, and you probably will make it. But you will have really bad feet and ankles for the rest of your days.
Well, not just that, you are guaranteed to have a head injury, a clavicle fracture, multiple rib fractures, a couple of spine fractures, intra-abdominal injury, a pelvic fracture, a long bone female tibia fracture, a pilon, and a cow.
Yeah.
Bilateral.
Yeah. The last of which take the least emphasis of all the things you're managing.
Yeah.
And that puts a huge strain on the system. These multi-system polytraumas that are coming through.
That's like 3 days worth of operating.
It is. Once you add them all together, when you add neurosurgeons to general surgeons to orthopaedics and max fax and the tracheostomy that happens at some point.
And the PPE turnover.
Yeah, absolutely. It's a huge drain on the system. And one of the things I liked about Alex Trompeter's talk the other day was he was talking about temporizing. Because that's something that patients are making it to theatre, but we haven't really got 4 or 5 hours to be putting a pilon back together fragment by fragment, or to meticulously put proximal tibia back together, or whatever. And so actually what we're finding ourselves doing is more temporizing stuff, where maybe you fix the block with some screws and then put a monolateral external fixator across it. And one of the take-home messages from his talk was, when you're putting on a frame, a monolateral frame, I'm not talking about circular, a monolateral frame as a temporizing measure. In orthopedics, we have this kind of thing of putting on a quick, dirty X-fix. X-fix is a quick thing. We put it on because it's quick.
And because you kind of accept, well, okay, this is going to hold it for a week to 10 days.
Yeah.
And there's definitive treatment. So you don't need to get it perfect.
Yeah.
95% good enough is probably good enough.
That's right.
To hold it reduced out to length.
Exactly. So X-Fix gets a bit of a bad rap because they're not put on particularly well, because they don't need to be high functioning. They just need to hold the leg relatively solid, keep the soft tissue stretched out, and then we'll come back at after a time period that is short, probably less than 2 weeks, and crack on with the definitive.
But the fact is, we then go on to, but then you get the opportunity to do definitive treatment, usually delivered by someone who has a subspecialist interest in that injury. And so you get perfect care. And we're in a situation where we can't do that at the moment.
Agreed. But you can make a massive difference to a patient by, when you put that X-Fix on, that monolateral X-Fix on, putting it on really, really well. So actually, rather than just slamming in some 5mm X-Fix pins, actually pre-drill them nicely and put some HA coated ones in over the top, so you don't burn the bone, so they don't get infected, they stay strong for long. Rather than putting just put a denim pin in the heel and maybe one of the first metatarsal, you put multiple pins in the foot and bring them up onto the bridge, so that you get the foot held nice and strongly, so they don't all become loose by 10 days. When you're at the end of the case, you are locking up all those bots gorilla tight, so that they're super strong, and really you're paying a lot of attention to the reduction. Really thinking about it and thinking in your head, this is going to be in this X-Fix, well, it might well be.
Potentially, that might be it.
3 months.
Yeah.
It might be 3 months. And also, when you're putting it on, why not do a reduction of the block while you're at it? Like put a percutated Weber clamp, squeeze some of those fragments together, maybe put a couple of small fragment screws across it just to hold the block together. Dealing with a metaphyseal non-union down the line really isn't a big deal. Dealing with intra-articular fragments that are like that's no fun at all, and that basically is, you need a fusion.
I mean, it's very kind of you to give Trompter all the credit. I think I mentioned it first in the intro, but let's not, potato. The fact is, a key temporizing. I think it's one of the key take-homes that you gave us in your summary was that the best possible temporizing measure, with a chance that could be the definitive treatment.
Yeah, and the other thing about a monolateral X-fix is that if you, particularly if it's around the ankle, or the knee, they are very, very heavy, and they weigh down the leg, which gets buried in the cover. So some kind of bridge underneath it to keep your foot and ankle off the ground really does stop you getting pressure sores.
And similarly, you want to make sure that no matter whether you're putting a wrist in a plaster, you're doing a knee X-fix, or you're doing an ankle X-fix, you want to make sure that that bit of the body is held in the anatomical position so that it's not going to cause any long-lasting sequelae.
Exactly right, and that really goes back to just paying a lot of attention to when you're putting on the X-fix to make sure that if this is 3 months later, your X-fix is still going to look like that, and the alignment that you've got here is what you're going to keep.
Upper limb. I think we agree that we can treat everything upper limb non-operatively. I tell you, when I was my second SHO job, I worked at Charing Cross for a guy called Dinesh Nathwani, and Din was funny. He was always chewing gum, and he was always late for the trauma meeting. Always late, and invariably he'd argue they got stuck behind a garbage truck,
right,
or a rubbish truck, and he'd say it all the time, and it became a real running joke. So if anyone was ever late for anything, a clinic or a list, you go, "I'm really sorry."
I got stuck behind a garbage truck.
Garbage truck, and everyone just nodded, and you'd kind of carry on, and he was. But Din was one of those guys who'd always give an opinion on everything in the trauma meeting. He's a knee surgeon. I'm not saying all knee surgeons think they know everything, but he would give an opinion on everything.
This one did.
No matter what it was, whether his area of expertise or not. And every single time they put up a proximal humerus fracture, like quick as a shot, within a nanosecond of the x-ray going up, before someone had even given a history, go, colon cuff, move on. And basically, whenever the upper limb guys will get a bit cross, so they discuss it, all the intricacies of the case, and they'd like talk about various aspects of it and the latest research, and they do like for 10 minutes. And the end of it, kind of sheepishly look at the floor and go, collar and cuff. And didn't be cackling away for the next 10 minutes. It used to crack me up. And so ever since then, I've kind of been by default thinking we can treat everything in the upper limb, particularly in the humerus, non-operatively.
So the thing.
I'm sure Olivier would agree.
The thing is, it is quite fun watching the torment in the upper limb surgeon's eyes when you say everything can be treated non-operatively. So that is enjoyable, and I think we all accept all lower limb specialists kind of like see the enjoyment in that.
But it's a sport. It's a sport.
But the truth is that we have to acknowledge that there are some upper limb surgeons, some upper limb injuries that do not lend themselves well to non-operative treatment. There are a bunch of them. For example, like up in the clavicle, you've got those type 2As, the ones where it ruptures, where the clavicle breaks just medial to where the ligaments attach. So the lateral part of the clavicle is still secured down to the coracoid, but the other one goes boing and it's stuck up in the air. You've got elbow instability, man. I mean, that is not a thing to treat non-operatively. That is a grisly business when that goes.
Yeah. That is a thing that can be temporized to a degree.
Yes, you could put it in X-fix, but again, X-fixes have to be really carefully put on.
I agree.
And
they're challenging in the upper limb.
Yeah, and hinged X-fixes at the elbow are really, really difficult to put on, because if you get your centre of rotation ever so slightly wrong, they just woo, it's straight out again. Elbow instability is a difficult thing to manage late down the line. It's something to treat promptly, not something to temporize really. Intra-articular fractures at the elbow. If you want to pick your nose, everyone listening to this, try and put your finger on your nose, and now look at your elbow. That's 130, 140 degrees of flexion.
Yeah.
So if you don't have that, you can't not be able to get your hand to your mouth.
Yeah.
Now your arse actually. You can touch your arse.
Yeah, it's not so bad actually.
It's not so bad.
Realised,
It's like about 90 degrees or so, maybe a bit less.
Yeah.
So you can. That's
your
fine.
arse is bigger than mine, but that'll be right.
But get your hand to your mouth or to your head.
Yeah.
Look at your elbow.
Yeah.
And so that's you do need a degree of flexion for that.
Talking about putting your hand to your head, just out of interest, you're looking like you've had a haircut. in the middle of a lockdown.
Yeah.
Listen, the rest of us walking around like it's look at this bush, like it's 1970s prime Terry Wogan.
So we went out and bought some clippers.
Oh, is that what happened?
It got desperate.
Yeah.
I you know, it was all fluffing around my ears.
Thinking,
It was all a bit of an embarrassment.
Yeah.
So Chloe went and bought some shears.
Right.
Slightly inexpensive ones, about 30-40 quid, like not the top end ones, and that was fine. So I did the buzzer.
Not Tony and Guy.
We practiced on the 6-year-old.
Oh, did you?
So he's got a bit of a lumpy haircut.
Social services.
And then she let rip on me, and she did a great job.
Okay.
There are bits that aren't.
No, I think you're looking quite sharp.
Yeah, and then I thought I would go the next step and do the dog with the same clippers. Unfortunately, the clippers just were not up to it. They weren't man up. So halfway through doing this dog, and she was like a sheep at the start.
Yeah.
So I put her back and her bottom, but basically she's now got these like two massively hairy legs. But otherwise she's completely short.
This is the dog we're talking about. I mean, Electronon in older patients, that is one that you can treat non-operatively.
In fact, I would argue that's one you should treat non-operatively. Yeah. Older patients with it, because that's the elbow is one of those weird injuries, isn't it? That you can have an olecranon fracture. You can have almost half the joint missing, and yet still the elbow is stable because the ligaments don't bind onto the olecranon. They come further forwards. So olecranon fractures are, and you don't absolutely have to have an extensive, strong extensor mechanism, because usually gravity helps you out. Yeah.
With regards, and then Livia talked about milking the capitellum.
Yes, so the classic capitellum fracture is like a sort of vertical shear of the capitellum, so it gets like shoved up out of the radiocapitellar joint up the front of the humerus, and but it's still got a tiny capsular attachment at the tops. So if you fully extend the elbow, if you can achieve that under II, and you can put your thumb on the radial head and push it down, that may re-engage it into the radial head, and then you flex up, and it's now jammed back in place again. So that was a quite cool little trick. Yeah.
I think we agreed that distal radius in older patients who are low demand is another one that's a good one for non-operative treatment.
It definitely works, because they do, in a low demand patient, they do tolerate a degree of malunion. That's the fact of the matter.
And perhaps we'd intervened on this. We've perhaps been operating on them a bit excessively.
Sometimes we can't help ourselves.
Years.
Yeah, that's right. Yeah, I agree. But we do have some evidence now that supports the upper limb surgery. As horrifying as that is, we now have some long-term follow-up on distal radius fractures, suggesting that malunion is a bad thing in the long run. And I know we feel that malunions can be tolerated in distal radius, and it certainly can in low demand. But in younger patients, does a malunion now, what does that look like in 20 years' time? And I think we've now got some evidence coming through that suggests that isn't a great thing, and that you never get your full function back. So it'll be interesting to see how that turns out. But the tide moves one way, and then it moves the other. It moves strongly towards volar plates, didn't it?
Yeah,
and then it went back to KYs again. Yeah. And now there's kind of like drift the other way, and inevitably it washes to somewhere into the middle.
Talking about proximal humerus, a humeral brace is a pretty forgiving piece of equipment if used appropriately.
For a humeral shaft. Humeral shaft, yes. Humeral brace is a great thing. They work really well. They do have to be tight though. Functional braces work on, circumferential compression. So you have like hydrostatic pressure within the compartment, and that holds the bone steady. If they're loose, they're really no good whatsoever. So it being tight, and the patient understanding they have to, tighten the Velcro straps periodically as the juice squeezes out of it somewhat is important. They are so much better than that miserable hanging cast thing. There's massive it's a humongous lump of plaster you put on these old ladies' arms.
U-slab.
Yeah. Oh man, I mean that's just torture, right?
It is.
Oh, patients love it when you take those guys off. They love it.
Tell us about Wallant.
Wallant, wide awake, local anaesthetic, no
tourniquet.
Wallant. That is basically, it's mainly for upper limb stuff. I guess you could do it in the foot, but it's mainly for upper limb things where you are putting a whole boatload of local anaesthetic into the arm, and try to
Regional
block
anesthesia.
it, regional anaesthesia, and then you can crack on with and it's regional anaesthesia with adrenaline in it. So it's long lasting. You get a bit of a tourniquet effect with that as well, and then you can do your upper limb surgery, do whatever it is you need to do. It's kind of been devised by the North Americans who, if you're doing your own anaesthesia, you don't have to employ an anaesthesiologist.
And you can operate immediately on seeing the patient.
Exactly. Yeah, you can literally there and then.
Hi there.
you need surgery. Oh man, no! Don't start doing American accents. That is painful.
You talked about when we talking about distal radius fractures in your case takeaway that you filmed in the laundrette.
Yes.
You talked about manipulating these fractures.
Yeah.
And you can even bring a mini C-arm down to fracture clinic. I mean, and keep it in there, right? In minus, where you're running minus.
Absolutely, because the mini C-arm doesn't need a whole boatload of lead shielding. You are supposed to be leaded up as the operator, as the person using it, but people in the vicinity, and I don't know the exact rules on it, but the vicinity that do not need to be protected. So a mini C-arm is a powerful tool in your fracture clinic, in your ED, if you're doing these manipulations. Yeah, absolutely, particularly under sedation, because otherwise, you give your sedation or ketamine, you do your reduction, you then go and get your X-ray, it comes back, actually, you've got to do it again. And you've got the sedation's got to happen again, or the monitoring goes back on. It's a real nuisance. So having a mini C-arm is a powerful tool for sure.
Talking about upper limb fractures, I'm joking that they don't all need to be fixed, because there are certain things that really need to be done, trauma and elective wise. For instance, a displaced GT fracture.
Displaced GT fracture, which is basically a rotator cuff, isn't it? A displaced, and what is displaced? Well, they say 5 to 10 millimeters, and you can tolerate a little bit of displacement. But the trouble about a GT is they remain potentially unstable. So you get an X-ray, but there needs to be some surveillance if you're going to treat it non-op. They can move at the 1 week, 2 week interval, and if you get a GT that displaces, or a rotator cuff that just rips off, so it's entirely a soft tissue rotator cuff injury, that is a real prick of a reconstruction. Those patients never get a great recovery, because you do need a rotator cuff for your shoulder.
That you do. What about NOFs? NOFs have been interesting because there was this. There's been a mindset amongst some people that, okay, we're going to have to treat NOFs non-operatively. That was one of the things that came out quite early when this surge first started.
Yeah.
But that hasn't really been the case.
That really hasn't happened.
And it wouldn't really be appropriate to do so.
No way. I mean, ask any orthogeriatrician. Dying in bed with a neck of femur fracture is a truly grisly way to go, because it's not like it kills you instantly. It's a slow, miserable demise over a long period of time. It's a horrible, horrible thing to palliate someone in that situation. And so, actually, the people that you palliate now are the same people you palliated before this COVID crisis. We did have a lady, like an 82-year-old lady. She was properly demented. She was, had a bunch of comorbidities, but the fact of the matter is, we would have fixed her before. We would have done the hemi beforehand.
After optimising her.
She had a COVID pneumonia. She was properly sick, and so the anaesthetist quite rightly said, "Look, doing it right now is crazy, but let's reevaluate in 48 hours." As it turns out, she should have died but didn't. She rallied, she shrugged off the viral pneumonia, and by God, we fixed her. And actually, she's been discharged. I'm not saying she's still alive now, but she did get fixed, and she did make it out of hospital.
We don't need that bit at the end. You ruined the story.
Oh.
I don't know if she's alive now or not. I'll edit that out later. With regards to pelvises and femurs, so there's always been this kind of slight mystery of pelvises. Nothing bores me more than an LC one. LC anything. Nothing bores me quite as much.
Quite reasonably, yeah.
And so we are still getting fragility fractures, and we will get more, for sure. But more specifically about pelvises, these high energy injuries, they don't really lend themselves to non-operative treatment.
They really don't. There was one of the points I made in the webinar, which is that we look at pelvises on X-rays, and so all we see is fractures. But what we don't see is this mass of like matted ligaments that sit around the SIJ, the spinopelvic region, the symphysis, the pelvic floor, all of that. There's massive ligamentous anchorage around the pelvis. So if you fall over low energy and you crack your pelvis, those ligaments are not ripped open, your pelvic floor hasn't gone, those bones don't want to go anywhere. You couldn't make them go somewhere if you tried. The ligaments are incredibly strong, and so that's a stable injury. Those do not need any kind of fixation. But if you rip through all those ligaments, so that in a high energy injury, it's hopeless treating those non-operatively, absolutely hopeless. And you end up with proper deformities, like pelvic deformities are pretty crazy. People all wonky, like they move, the pelvis, hemipelvis moves in like weird rotational ways. So you end up with, like people being twisted round. You get leg length discrepancies. You get sitting imbalance because obviously your ischial tuberosity is now at different heights. So you like sit over on the piss and you're leaning over. I can see you glazing over here.
Sorry, I actually wasn't I? That wasn't intentional.
And correcting a pelvic malunion is not the same as creating, like doing a tibial osteotomy. It's really quite a big deal to do, and generally the outcome is you leave it like that forevermore.
Otherwise, and the alternative is to leave them in bed and in hospital at risk of catching everything, of getting everything, on traction.
And so if you go back to the premise, this premise of we're now going to be doing everything non-operatively, yes, I think it's definitely made us look at non-operative treatment much more seriously and question our indications for surgery. But the truth is, if you're doing non-op treatment on something, whatever it happens to be, non-op treatment on something, that still requires often weekly returns to fracture clinic to make sure it's all in a good position. It requires a degree of expertise when you're applying the non-op treatment. So you're putting on the plaster, you're putting on the, you're putting on the splint, you're putting on that humeral brace, whatever it is. It does require a degree of expertise to get it right.
Particularly if you're looking at traction.
Right.
And traction is a bit of a lost art. I know that the Peace guys do it, but
yeah.
For I'm not sure we've even got much traction stuff lying around, have we?
Yeah, all of our bulk and beams and things have been stripped out of the hospital. I put up a few slides about balanced traction, and wouldn't it be lovely to have all that? Just that we had a traction cupboard in the old hospital. Yeah. That all got trashed instantly. We moved to the new one and never got replaced. So the way we put on traction nowadays is a bit embarrassing, but we justify that by saying, well, they're going to get an operation in the morning, so it's okay.
Yeah. So you don't mind, but then you don't mind
hanging a bag of saline over the end of the bed kind of
Okay.
seems okay in that context.
Yeah.
But when there's a queue for theatres to get that femur nailed, and people are staying in bed for 2 or 3 or 4 days, it makes you look at that traction and think that this patient is not doing well here.
We haven't really talked about knee injuries, and there are intra-articular knee injuries. We've seen a couple of locked knees from a couple of large osteochondral fragments. We've seen some bucket handle meniscal tears. There are still certain things that happen in and around the knee that need to be treated acutely. Yep. But I appreciate they fall way down the list when it comes to ventilating patients and the open fractures and pelvic fractures, some of the other things that we have.
Of course they do, but it's like all these things. This is part of the building pressure of cases that is going to need to get looked at once we're through this, and actually picking them up as they come through is no bad thing. So I don't think we should be stopping operating altogether, because all we're doing is pushing problems down the line.
And it's not stopping; it's more getting access, because obviously they get trumped by other things there. And that's, I guess, where we're working with some of the private hospitals locally to get, and Stanmore have come back online. For trauma, and so it's now the time of getting these cases done there and other places. A lot of hospitals around the country have the option of an elective centre where they can do cases. We don't have that same option at the moment.
Yeah. So we're using Stanmore as a non-COVID trauma centre, which is great for isolated extremity trauma.
As we go around the body down to the tibial plateau, I enjoy the conversation about the tibial plateau. The fact is, there's a suggestion that we maybe do over-operate on them.
I think we're over-operating on tibial plateaus, but the trouble is we can't help ourselves, because we get these beautiful CTs which show an articular step. we know that we can bring that articular step up and fix it nicely, and the patient, and the complication rates are pretty low, and so we tend to just crack on and do that. But the fact is, we probably don't need to. Yes, we are over-treating that injury for sure.
And it is interesting because it is, so whilst it is the most important joint in the body, you do say that you're right.
It's also one of the most forgiving.
It is. There was that Canadian study that said, 7% had gone to arthroplasty at 10 years?
That's right, yeah.
I mean, those are damn good odds given the, and that was all comers. You're talking about Shaska 6 in there.
Exactly. And the Edinburgh, and a similar study from Edinburgh showed it's less than 3%. So it's incredibly low rate of arthritis following tibial plateau fracture treated operatively. Yes.
One of the things that you mentioned was, and Alex mentioned as well, was talking about assessing stability. Because obviously, when you know the lateral side, the lateral compartment is a very unforgiving compartment, and you can fall into valgus. And you talk about assessing stability. Just tell us about that again.
So and the valgus instability is the thing you have to rule out. And the clinical examination goes, you have the patient, you take their hinge knee brace off, and you cradle a leg in your hand exactly as you would do in clinic, and you're basically just applying a gentle valgus force. And normally in a tibial plateau fracture, actually the medial ligament's intact. It's not like it's a medial failure, it's a lateral failure. And so you just pull it into valgus. Now you're not absolutely jacking it as if you were testing a ligament, you're just feeling for an endpoint. If you get an endpoint and actually it doesn't fall into valgus, that is a stable knee. And whatever the CT shows you, it's stable. And the meniscus will protect the joint surface, and the likelihood is that will go on to a good result. So I must say it's not been something that has been particularly part of my practice, if I'm honest, because we tend to go in the trauma meeting. We look at that depressed plateau and we say, yeah, hell, I'm going to fix that. Yeah. But the truth is you probably don't have to. In a lot of cases.
When we're assessing valgus for ligamentous purposes, we're normally doing it in full extension at 30 degrees of flexion, just to assess the MCL in its optimal position. Are you talking about, when you're assessing for your fracture stability, are you talking about in extension where they may be weight bearing?
I think you can go into extension, but you're actually, to put a patient with a tibial plateau fracture right into full extension is really tough, because they've got a big hemarthrosis, and that's a really sore knee. So inevitably it's probably in 5, 10, 15 degrees of flexion anyway, and you're feeling the valgus stability in that position.
Tibial shaft is an interesting one, because that's something that we know we can nail pretty reliably. And since with the introduction of suprapatellar we've got even better at them.
Yeah.
And so you can nail almost right down to the plafond.
Yeah.
But the Sarmiento stuff never been really well. No one else has reproduced it quite as well.
So Sarmiento did these, just basically spent an entire career treating tibial fractures non-operatively, and there was a real science behind it, and he published a whole load of papers, and nobody on Earth, on planet Earth, has been able to reproduce his results. And I think the general assumption now is everyone's very respectful, of course. Wherever it was he worked.
Is he dead?
I don't know if he's dead. I think he probably is dead.
I don't know if he's going to sue us. That's kind of the first thing that comes into my head. I'll look it up.
Look it up, and then you can decide whether to leave this bit in.
Yeah. But the tibia doesn't like a rotation, malunion.
The tibia does not like malunion. Period. It does not.
Valgus, varus, shortening, rotation. It doesn't like any.
Doesn't like any of it. Well, shortening is just a pain in the ass. The patient's like clomping along. Yeah. Patients, more than a centimetre or so, patients do not like it. And once you're above 2 centimetres, they say, centimetre and a half, you can compensate for. But actually, once you go above a centimetre, patients do feel it. They don't like internal or external rotation because you have to adjust your knee to compensate, so you walk straight forwards.
That causes knee pain, hip pain, back pain. Exactly. It goes up the chain.
Exactly. And then an angulation brings on adjacent joint disease, which is painful. And the beauty of a tibial nail is it in general, as long as you get it right, it obliterates those problems.
However, a tibial shaft fracture, a diaphyseal fracture is one of the things that you can come back to correct.
Agreed. And so an osteotomy is a thing you can do. And I like what Alex said about you make a contract with the patient before. If you're going to treat them non-operatively, that is fine, but the patient needs to understand that this may go on to develop some kind of deformity, in which case an osteotomy is what they're looking at. Tibias actually do generally go on to heal. They heal. Although we're brought up to think that tibia is a terrible healer, if you keep it closed, it does generally heal, but it has a tendency to malalignment because the soft tissues around it are imbalanced.
Yeah.
All of the meat is posterolateral and there's nothing anteromedial.
And I guess the challenge is that if you nail a tibia, you can get them up and walking on it straight away.
Exactly.
As opposed to 10 weeks of non-weight bearing.
I mean, the benefits of operative treatment of tibia are pretty overwhelming. Same as a femur.
I'll tell you what I haven't seen in about 10 or 15 years.
What's that?
Is a bit of cork.
Yeah, what jammed into the plaster? Yeah.
Wedging the plaster.
That's it. Yeah, and you see on the X-ray, see these bits. Yeah,
that's a lost art.
It's a lot. Well, was it ever an art in the first place? I sometimes wonder. Was it really? Was it really?
I've seen some really. I remember as an SHO seeing some really quite spectacular stuff where something tibia going to valgus, wedge plaster, bit of cork, straightened it out, healed straight. We've seen some really quite impressive results.
Yeah.
I appreciate this is anecdotal, but every plaster tech would have a bit of cork in the back pocket. And I'm saying you don't see that anymore, do you?
No, I mean the plaster techs now just don't get involved with that. But I must say I tried it on a few occasions as a young enthused orthopaedic surgeon.
Right.
I never got that to work. I always put the cork in the wrong place, or the cork wasn't quite big enough.
Yeah.
Usually just made no difference whatsoever.
If we move on to the ankle.
Yeah.
I know you love the FAME trial.
I don't love the. I love what. I do love the FAME trial. There it is. I said it. I said it. I love it.
Just be proud, Pete.
Let me tell you why I love the FAME trial.
Be out proud. Tell us.
I love the FAME trial because of the commotion and angst that it has caused amongst the orthopaedic community. I love the way it has challenged the foot and ankle community to the core. A lot of those guys are really, really troubled by the whole premise. And because the fact of the matter is, treating unstable ankle fractures non-operatively is a truly jarring change from what we've done historically. I was asking Gareth Scott, one of our senior colleagues, he was like...
Professor Scott. He
was like... He wasn't quite a professor, but he was damn near a professor when I was still a medical student.
Yeah.
He's a proper, what you would call one of the senior guys in the department. He cannot remember a time when ankle fractures were treated non-operatively.
Yeah.
It's not like they used to be and then we moved to fix them.
Yeah.
They have always been fixed since the dawn of time, it seems.
Yeah.
And yet, here we are thinking that maybe that's a good idea. And I love it. I love it.
I know you do love a little bit of commotion. I'm still really uncomfortable with the amount of medial malleoli that you leave alone. It doesn't sit well with me.
That's right, because we've been brought up fixing every single ankle fracture, and we've been told that every single medial malleolus has a piece of infolded periosteum that will never heal, and it's going to go on to a painful non-union. It's all going to be a disaster. And I love the way that someone is bringing out a trial that's making us look at that again. It may well turn out that non-operative treatment of unstable ankle fractures is a complete no-go, and there was a reason why we fixed them all the way through, and let's not go there ever again.
And we're open. You and I, we're in complete equipoise here.
Well, no one's in equipoise, are they? Really, truly.
I just love saying equipoise. Andy Price at Oxford. Every conversation I ever had with him, he'd use the word equipoise, and I just love using it. It's almost unprecedented how often he would say equipoise.
Everyone has prejudice. Nobody has equipoise. Yeah. Whenever a trial comes out, you always think you know what the answer's going to be.
Yeah. Well, it's like the life trial.
Exactly.
Right?
Yeah.
I know what the answer's going to be. The answer's going to be that those that you operate on get out of bed slightly quicker and have slightly less pain, but they have a slightly higher rate of complications in terms of infection and other iatrogenic things.
Yeah.
There you go.
Why bother?
Give me the 3 million. Give me the 3 million. I'll do something good with it.
I love that someone's challenging the bedrock upon which we've founded the management of ankle fractures.
Yeah,
I love it.
The thing I'm loving, I am loving some of these UK trials, these pragmatic trials.
Yeah.
Because we've always looked to the States for answers.
Yep.
And there's a whole bunch of reasons why what their practice isn't necessarily directly applicable to what we do. And the fact that we've now got people in the UK addressing this, leading the way, I'm loving it.
Agreed. And the other bit I particularly like is that the whole country is now randomising, is providing patients. We've kind of got over our institutional pride of like, I'm going to provide a case series of 16 patients and somebody else's and all the rest of it. At last, we're all putting our patients, recruiting into central studies.
Okay,
And
I found this on the web for series of 16 patients at last.
Siri's always got something to say.
She has to butt in, don't you? She's worse than my wife. Just stay out of it, Siri. I think this will change the way we practice in the future, and I think once COVID is gone, I feel there are certain injuries that we would have operated on before that we'd feel more comfortable treating non-operatively.
Yes. Definitely given us the confidence, hasn't it?
Yeah.
Yeah, it has. And made us look at ourselves a bit more, yeah.
And what we don't know is that what if there is a second wave? What if coronavirus mutates and comes back in a year's time?
Yeah.
As COVID-20?
Yeah.
We need to be prepared for that.
Yeah.
And so I think people will look to stockpile certain equipment. We might get traction stuff back in. We may make sure we've got enough gowns and masks to survive a nuclear apocalypse. And realistically, I think as a result of that, we're going to be of a mindset that what if this or something similar happens again in the future?
Yeah.
And so I don't think everything's going to be the same.
I don't think it is. I think I think it's made us look at ourselves as a specialty. It's made us think about the fact about how heavily we lean on operative treatment of things. And yes, I think there are a bunch of injuries that now that we will feel much more confident treating non-operatively, feel much more empowered to treat non-op.
I know that there was
but I have to draw the distinction between non-op and
neglect.
That really is a fundamental thing. There's non-operative treatment is something where you often do a thing, you do a manipulation, or you carry out a positioning thing, and then you're x-raying in a serial way afterwards to make sure it's all going well. And if it's not going well, you intervene, not necessarily operatively, but you will change your tactic,
as opposed to
remanipulate, or change a plaster, or
as opposed to putting someone into a plaster at day 0 and saying take it off for 6 weeks.
Exactly. And some of the people in the webinar were suggesting that those were instructions that they were being given. The BOA guidelines have said it's fine just to treat things neglectfully. No, that's not what they've said at all. What they're saying is, if you're going to treat non-op, you still got to give it some surveillance. But just putting something in a plaster and managing the crisis, the problem in 6 weeks' time that's not non-op treatment.
And the thing we mentioned was that the neglect can be indirect. It can just be that you did not get to operate on it during the window that you wanted to, because the patient got COVID or had some other issue, or you couldn't get theatre space because there were there's no ventilators available. There's a whole bunch of open fractures going on, or other things.
That's it.
So it may be that you don't choose to neglect it, but indirectly you do.
Inadvertently, you get there, and that goes back to Alex's point of good temporization. So if you're going to put on an X-fix or put on a cast, make sure it's a good one. If you're even going to put on traction, make sure the patient's set up well. They've got a bump under their leg, and it's pulling along the line of the femur. Yeah.
So we're here at Barts. We're interviewing for Professor of Orthopaedics in a couple of weeks, clinical orthopaedics.
We are.
I think that's supremely exciting.
It is really exciting. Yeah, our charity has supported a whole professorial unit. So it's a professor, but it's also a couple of senior lecturers, a bunch of research associates underneath them, and also clerical staff to go with that. So our entire sort of professorial hierarchy associated with the University QMUL, which is it's tremendously exciting. Real massive change for the department.
And the fact is, we have a huge amount of patients, a huge amount of substrate here, a lot of great work going on. It'd be interesting to have someone look at that. And I'm excited because I'm very much of the belief that a rising tide lifts all boats. As you know, I've said that before, but I genuinely believe that. And so I think it'd be super exciting to get a professor in and to work with them. So it'd be good fun.
Make us all look good.
Maybe we might. That's more than it. Yeah, we might be getting.
I drowned in the rising tide.
Yeah, someone stood on my head and held me under the water. We might even get whoever it is onto this podcast at some point.
You never know. You never know.
You never know. But I imagine they're probably too sensible for that. Pete, if I ask you to summarise what you think the key lessons at this stage during COVID-19 and the orthopaedic decision-making process, orthopaedic practice? What would you say they are?
So I think there are some related to how you manage your orthopaedic service in a constrained environment, particularly in a theatre constrained environment. I would say if you are going to take people to theatre, try and make it the definitive thing. And so that is really excellent temporisation, and we've covered that.
And moving away from span and scan for now.
Exactly, yeah. And quick, dirty X-fix. Try and get that out of your head. I know we can manage our clinics a lot better. I think everyone has learnt that lesson. And there's probably, almost certainly is a role, to a greater or lesser extent in different subspecialties, for virtual consultations.
Be it telephone or video conferencing, there's been a huge, I think that's something that's going to be here to stay. In general practice, it's widespread.
Yeah.
And even for a lot of the things that we do here, that will stay.
Yeah, and actually for attending meetings, managerial meetings as well, a lot of those are now virtual, and they work so much better because people are a bit more punctual and a bit more to the point when it's in a virtual environment, I found.
That's been the interesting thing, doing all these Zoom and GoToMeeting. Having the MDT on a GoToMeeting has been fantastic.
It has, yeah.
Absolutely has. Brilliant.
But people are slightly less self-indulgent in that setting because people feel a pressure to get on with the meat of the meeting. Whereas in a real-time meeting, everyone sits down, they're all very comfortable, and everyone has to do their chest puffing and say their little bit.
Let me just bring up the 3D recon of the pelvis.
That's right, yeah.
Let me just talk you through the base approach. So people aren't hosting mini TED Talks anymore during trauma meetings. So there's something to be said there.
From the point of view of non-operative treatment, I think we've learned we've been empowered, let's say, to treat a lot more non-operative than historically we have. We know that high energy injuries in general across the piece, upper limb and lower limb, but particularly around pelvis and femur and tibia, really don't lend themselves to non-operative treatment because all of the soft tissues are stripped, and so the bones are just wobbling around, and they do need surgical stability to get good outcomes. We know that the tibial plateau is probably more amenable to non-operative treatment than we've traditionally thought it would be, and stability and alignment. Stability being the important thing, which is clinical examination. On that point, and it's something that Olivier brought up, if you're going to treat someone non-operatively, it is a bit of a contract with the patient, so discussion with them and involving them in that decision making is really critical. But also clinical examination is something that's very important. The plateau is a nice example, but the distal radius is another, elbow instability is another. The point being of clinical examination is you can document your findings, and now that puts you in a whole different sphere, medico-legally down the line, in terms of justifying the treatment that you instigated.
And as we have always documented our conversations with the patients, it is worth adding in the COVID-19, because the time may come when people forget what was going on at the time and why you didn't intervene.
That's it, absolutely right. So patients are involved in that decision, and they feel like you examined them, and they feel like that their injury was appreciated by you.
And shared decision making always gets better results.
Absolutely right. And the last thing we don't know, the thing we still don't know, is whether ankle fractures can be treated non-operatively or not. We remain in equipoise.
We're in equipoise, so we'll wait and see. We'll wait and see. The other thing that's been interesting for me is that generally orthopaedics as a community has been quite agile. I mean, hospitals have, to be fair. Everyone has moved quite quickly. It's so funny, isn't it, that we've talked about doing remote MDTs and things for years, and then all of a sudden we can set it up within 24 hours.
Yeah. And we're sitting there thinking, why didn't we do this ages ago? Absolutely
There's
right.
so many things that we could have done.
Yeah.
And that we've achieved so quickly. And so as a community, we've been quite agile, I think. I think as a department, we've been very cohesive and supportive. And so I think there's been some very positives that we can take out of this.
Yeah, agreed.
There are a proportion of cases that we have temporised that may go on to be absolutely fine. And there are a proportion of those cases that will need surgery later down the line.
Absolutely won't.
There are guaranteed fragility fractures at home that we don't know about at the moment. There's a huge burden of everyone I see now is out running and cycling. Yeah. There's going to be all kinds of injuries that present further down the line. So there's going to be a huge surge in what we need to do later down the line.
Absolutely right.
And I know you're already planning capacity to try and match that.
Yeah. There's going to be a massive wave of trauma coming through, and it's going to be both acute stuff because people are just like so pleased to be alive and outside of the house again, and be getting drunk down the pub and having fights again. But at the same time, there's going to be the recon element of patients who were treated non-operatively or treated operatively, but just weren't. There wasn't quite the time to do it as definitively as you might have liked, and all of that is going to have to come down the road.
And if you need any more information, please do go to www.orthohub.xyz. We've got a YouTube channel. Have a look at that. We do need you to. I need you to hit like and subscribe. Do we have a MySpace, Pete?
A MySpace?
Yeah.
I wouldn't even know what that is.
TikTok? No, TikTok. We've got the YouTube, we've got Facebook, we've got Instagram, and we're on LinkedIn. We are media whores.
No TikTok.
No TikTok.
Why not?
You actually know what TikTok is?
Yeah, it's like Facebook in China.
Not quite, but yeah, we'll get a TikTok. What could possibly go wrong? The end of the world could happen. Zombie apocalypse.
See you next Tuesday.
See you next Sunday.
In 1972, a crack commando unit was sent to prison by a military court for a crime they didn't commit. These men promptly escaped from a maximum security stockade to the Los Angeles underground. Today, still wanted by the government, they survive as soldiers of fortune. If you have a problem, if no one else can help, and if you can find them, maybe you can hire the A-Team.